The point you made, Nirmal, earlier, we're a resource-rich state in a very, very wealthy country, a first world country. Every hospital in WA, in Perth, was said to be in bypass, except for Rockingham Hospital. The second common element, which comes to about 37 out of the 40 odd cases, is something that is very dear to your heart and my heart, Nirmal. 37 of those cases are from the Indian community. Why? And there could be two reasons. The first is that because I'm Indian, they're coming to see me. That then raises the question, the point that you made earlier, what about all those people that are impacted that don't know where to go? Now, the Indian community happens to know, they've seen me on TV, heard me talk on radio, and they know that I'm someone who understands their culture and might be able to help them with the issue they're dealing with. But what about everyone else? Why is there no one standing up to talk for them? A journalist then asked the current health minister whether she could guarantee that an ambulance will be used in all those cases. And she said, I can't. You have to be able to give a guarantee that that protocol will be followed. And I guess in some of the other cases, they've come back and said, yes, we didn't follow the protocol that was in place. We made a mistake. We did something wrong, not in accordance with our protocol. And so now we're coming in with a new set of protocols that will be put in place. If they aren't following the existing protocols, what chance are they going to have to follow the new protocol? In Ashwath's case alone, there were 33 recommendations made. How many of those are now in place? I don't know, because no one has reported back to Parliament as to whether or not all of those 33 recommendations have been implemented. Yes, the recommendations come out, but the recommendations, they're not action items that need to be put in place.
Hello, everyone. Welcome to another conversation on Perth Dialogues. We all have seen the recent news in WA media and in the national media as well on the case where a mother was told to go from Midland Hospital to Rockingham while she was in labor or she was about to give birth. And she and her partner couldn't even travel that distance of about 60 kilometers. And in a country like Australia, in a rich and the most resource rich state like WA, she gave the birth on the side of a freeway. We are in that situation. And when I read about it, I saw that that's not just one of a case. The hospital in Midland had been on a bypass for many months. It goes on bypass again and again and again, meaning that it can't take any more mothers coming in to give birth. And this is why I wanted to know what is the situation of our health system and what the people of WA and people in general in Australia can expect from our health system. I know someone who has worked in WA health system and advocated for consumers and patients for so long. And I thought this will be a great conversation and learn from his knowledge and learn from his experience of what are the problems in WA health system. And he has got some very good suggestions to potentially solve them. So we go through them on what he suggests. Allow me to welcome our very own Suresh Rajan ji. Suresh Rajan ji, I've known him for many years, and thanks to him, he has been on Perth Dialogues in an earlier conversation where we went through his life journey, his personal journey. and maybe we'll take it from there. Welcome, Sureshji.
Nirmal, very nice to see you again. It's been a little while since we've seen each other, but it's nice to see you. Can I just start with talking a little bit about that particular case that you mentioned there of Lena and Abdul? Lena and Abdul they're a young couple. Lena is about 26, 27, and they had run their pregnancy at Midland Hospital for the entire time of the gestation period. And on the day that she gave birth, that morning at about 2 o'clock or so, she measured her contractions as being about 10 minutes apart. And they rang the hospital, and the hospital said, "Come into the hospital and we'll look after you there. And let's see, because you're close to delivering." So they arrived at the hospital at about 2:30 in the morning. Sorry, no, about 4:30 in the morning by the time they got there. And they were asked to wait in the maternity admissions waiting area. They were there immediately. An examination was done, a vaginal examination was done, and they determined that the baby was due to come very soon. They then decided that they would leave them there and come back and look after them at some point later. They sat in the waiting area for 4.5 hours with no one coming to see them in that entire period. You consider that this is a lady who's about to give birth, and no one came to see her in that 4-hour period. At the end of the 4-hour period, at about 8:30 in the morning, they came to her and advised her that the hospital has now gone into bypass and she had to go somewhere else to give birth to her child. At that stage, the contractions were 2 minutes apart. In other words, the baby was due to arrive very soon. They then rang around to all the other hospitals in WA and discovered that almost every one of them was in bypass. The point you made, Nirmal, earlier, we're a resource-rich state in a very, very wealthy country, a first world country. And every hospital in in Perth, was said to be in bypass, except for Rockingham Hospital. Now, for those people who don't know the geography of Perth, that's a good 60-minute drive away. My thinking would have been, if the baby's about to be born and the mum is struggling with that, put her in an ambulance and take her there. Because if she gives birth in an ambulance, that's not a problem. There are qualified people around. It is a sterile environment. They could have dealt with it. The paramedics could have dealt with it. But no, they asked her to go out to her car, climb into the Toyota Kluger, and her husband then got in and drove her and literally got 30 minutes away, got to about Atwell on the freeway, and baby Sophia decided that she was going to come along. And she arrived with a cord wrapped around her neck and potentially could have died there. Abdul did all the work necessary to deliver her with the paramedics on the phone and talking him through everything that needed to be done. So he did that. Medics arrived and saved the life of the child. But I don't get this. This hospital that was in bypass was exactly where they took the mother and the baby to back to Midland. And she stayed there for 3 days. So, hang on, this hospital was in bypass. Half an hour ago, it was in bypass, and the hospital now has accepted the ambulance bringing her back. So how does that work? And to their credit, the care that she got from that point on was very good, and the baby is well. But the potential now for postnatal depression to set in because of the trauma of the birth. And I've had many conversations with Lena, and it's fair to say that she is struggling terribly. When we've talked about going to meet with people to talk about exactly what happened, she can't bring herself to talk about it because she's so agonized about the whole issue. So, your points about a first world country, a resource rich state which has a $40 billion surplus, we're talking about significant amounts of money. And we have a whole group of people arguing that we should cut the migration numbers. But this is going to happen more and more if we don't have the staff to actually deliver the babies in the hospitals. So, what it highlights is a number of things, a number of issues that should potentially be dealt with. We've got a staffing problem. We know that. We know that we can't fill the health positions to the way we want to. We've got a significant issue there. We also know that we've got an issue around the planning. Surely, we know that the birth rates have increased markedly in Western Australia. We know that in Midland, there's a significant, I guess, there's a real strain on the health system of the hospitals that are in Midland. So we need to understand that the only way you're going to alleviate that is to put more money into the system and try to get to a system that is much more robust. Interestingly, also, that issue around putting her in her own car and sending her off. One of the recommendations that came out of this case was a discussion by the hospital to say that we need to change the protocols of this state to say that where the child is about to be delivered or mother's about to give birth, the only way they should be transported from one place to another is by ambulance. Okay. We're also looking at some changes that will occur at Midland Hospital. What they're trying to do is to now take part of the corridor and convert it into an emergency ward for a case like Lena's, where there's no room in the wards, but you can take a delivery in the hospital. Even if it's the corridor, at least it's in the hospital. At least it's in the sterile environment. Make better use of the facilities you've got there. Make better use of the services you've got there. But I guess the other thing also there that you touched on, Nirmal, was the issue around this is not the first case that I've dealt with. I sat down and went through my cases the other day, and I now have 43 cases of this nature that I'm dealing with. That's a huge task of dealing with all sorts of issues. A number of them are in the maternity area. So we have a problem in our maternity delivery space. So we're building a new maternity hospital. But that's going to take another 7 to 8 years to get here. What are we doing in between? We need to bolster the capacity of every hospital that is already doing maternity to deal with the issues that they've got now. So the 42 cases, and I've given evidence at a number of inquests about the issues that have resulted in the deaths of a couple of children, as well as a mother who's just given birth. So there's some very, very significant issues. Now, the coroner asked me whether I could discern any common element amongst those 40-odd cases that I'm doing. And there are two things that stand out in those cases. The first is that the doctors and health professionals are not listening to us. We know our bodies best. We know what's happening in our body. We know what needs to be done to alleviate the pain, need to deliver the baby, any of those things. We know better than anyone else what's happening in our body. So that's one, we're not being listened to. There was a recent study done by Monash University looking at that issue of listening to the patient, and they found that there was a close to about a 60% better outcome if doctors listened to their patients and did what the patients were asking them to do. So that's one common element amongst almost all of those cases. The second common element, which comes to about 37 out of the 40 odd cases, is something that is very dear to your heart and my heart, Nirmal. 37 of those cases are from the Indian community. Why? And there could be two reasons. The first is that because I'm Indian, they're coming to see me. That then raises the question, the point that you made earlier, what about all those people that are impacted that don't know where to go? Now, the Indian community happens to know, they've seen me on TV, they've heard me talk on radio, and they know that I'm someone who understands their culture and might be able to help them with the issue they're dealing with. But what about everyone else? Why is there no one standing up to talk for them? Why is there no one out there? Or is there? There are organizations that, like the Health Consumers Council, that exist that can deal with this space. But it would still seem that the people are coming to me because they know me from seeing me around and seeing I guess to some extent, the level of ferocity with my advocacy. I tend to be relatively fierce about my advocacy and I'm reasonably well connected simply because I've been here for 52 years and know lots of people because of my media profile, etc. So that's one issue. They're coming to me because I happen to be of the same cultural background. The other issue is that we are severely overrepresented. Why are we severely overrepresented? And I think it goes again to our culture. We're not the type of people that are demanding. We've come to this country, we receive a level of service, and we're grateful for what we get. We don't want to rock the boat. We don't want to make any noise about it. And we also, in our culture, elevate the medical professional to a status one step below God. So we've elevated the doctors and the nurses to that level. And therefore, when they say something, we accept it. So, Shandipan's family, Sanjoy and Saraswati, asked on 5 occasions for a blood test to be done. And on 5 occasions, the medical practitioner declined. A day later, that 21-month-old baby was dead. And he died from a blood-borne disease that would have been picked up a day before in a blood test. And if it had been picked up, it was leukemia. If it had been picked up, there was a 98% chance of survival. We went and asked for blood tests. They said no. We didn't thump the desk and demand that it be done. But you can't predicate a health system on how loudly the patient shouts. You've got to have a health system that immediately responds to something that the patient or the caregiver is asking for. That's the part that's missing at the moment. And I accept that no one goes to work wanting to inflict damage on someone else. Every one of those health professionals are professionals. They are caring. They are incredibly, concerned about patients' welfare. But what is it that leads them to this position? There's so much work There are so many patients, and it is literally a production factory. So people are going in at a rate of knots and coming out at the rate of knots. Another case that I'm dealing with, a young fellow, 21-year-old Indian boy again, has gone to watch a soccer match, AC Milan versus Perth Glory, up at NIB Stadium. He's rushed to go to the seat because he's running late, he and his brother. When they get to the seat, his calf muscle's hurting. So he thinks, oh, it must be all that running I did to get here. So I won't worry about it. I'll just put my legs down, make sure I'll just keep it stable. Sat through the game, rushed back to their car, got home, 7:30 at night, got home, and his mother looked at him and said, straight to the hospital. Took him to Armadale Hospital, where he had 4.5, he was there for about 7 hours all up. They did a few x-rays, and after 7 hours, they discharged him and said, if the pain gets any worse, come back in 3 days. Go and see your doctor in 3 days' time, your GP, and see what happens. He's in agony, absolute agony. Goes to see his doctor on the Monday. So this is on the Friday. Goes to see the doctor on the Monday. As soon as he walks in, it's an Indian man who's the doctor. The doctor's taken one look at his leg from across the table and said, get down to emergency immediately. You are developing compartment syndrome. He got down there immediately. 4 hours later, they took him into Royal Perth Hospital, and they're talking about amputation of his leg. This is a boy who was 1 week away from his final interview to join the Navy. And now he's got no capacity to do that. He can't finish his studies. Again, it is the way you communicate with us as a community, with us as people who are taxpayers, who are people in our community who want the same services that everyone else is getting, but we're not demanding it. But you cannot base a health system on demanding how loudly you shout and so on. So it is a concern to me that we have a significant number of our community members there. And it's a concern to me that we're not being listened to. So that then raises that issue that you're raising, and you're about to ask me a question, so I'll wait for that.
Yeah. So actually, I read your letter in the West Australian,
Yes.
where you called for an ombudsman to sit in the health infrastructure, the whole infrastructure, and look at these complaints. So I was thinking, here is a suggestion. Suggestion is suggestion. But the suggestion of an external body comes when the internal structures are not listening. And this is what I'm trying to ask you. The first question will be, are the complaints because of racism or miscommunication or something? Or is it that we have not built our capacity of the hospitals over 5, 10 years, 15 years, that we are at such place where there's so much demand for health that there's bound to be all these cases where people are not looked into, or the health professionals don't have the time to give focused or considerable time and attention to each patient. They have to rush from one patient to another.
I think you're absolutely right, Nirmal. There's a combination of both those factors. One is the not funding and not building the infrastructure. Now, I did propose a medical ombudsman, but another thing that I'm working on with the health professionals at the health department, and the Director General has been absolutely brilliant in this, was I've been proposing that every hospital, every ED department should have an advocate present 24/7 at every hospital, there should be an advocate there, or patient advocate. So if I'm the patient advocate, and let me emphasize, I don't want the job, okay? I have enough to do without having that job. But let's assume that I'm the patient advocate. Nirmal brings his child in to have something done and doesn't feels like not being able to communicate to the doctor his concerns about the status of his child's health. He can immediately contact the patient advocate to say, I'm not getting through. Can you come and help me? And the patient advocate, someone like myself, knows the escalation pathway that says, I can take Nirmal from the ED department to a senior doctor who can look at that child immediately. Now, I don't know that that necessarily will achieve success in all those failures that we've had, but I think we will make quite a significant improvement. Now, when Aishwarya died, we created the Aishwarya Care Call. Every hospital has the pink telephone, pink being Aishwarya's favorite color. If you feel like you're not getting anywhere, you pick up the phone and it goes straight through to a senior medical professional. That's the aim of the exercise. We don't believe it's working to its capacity. We think that a lot of those are being bypassed, those phone calls are being bypassed to the nurses' quarters, and it's not going to the people that we want it to go to. So this is an Aishwarya Care Call, but an actual person present. The advocate is there. I've proposed that we also go one step further, and that advocate not be employed by the health department, because how is it possible for an employee of the health department to advocate against the health department structure? So I want that person to be employed by a multicultural group, the Health Consumers Council, the Multicultural Women's Health Network, whatever it is, outside of the health system, so that they're not beholden on the health department giving them a check for their pay. They're getting paid by somebody else. But it needs to be funded by the health department and the health budget. So the health budget allocates X number of people. Now, we've put in a budget submission, so it's now up to government to decide whether or not the budget will accommodate. And we've asked for 12 full-time equivalents. That's a starting point to roll that out into some of the ED departments. The next issue, of course, is why only ED departments? This issue is going to be something they're going to feel at every ward. So we need to have an advocate who is available not just to the ED department, but all around the hospital. Concept is great. Since I first wrote about it, it got picked up by a Canadian mob, and the Canadian health authorities are now in touch with me. And they'd come and talk to us in Canada about how we can do it as well, because they love the idea. It's simple, but it can work. So that's one. The Ombudsman is, there is a complaints mechanism, there's a complaints process. I think all hospitals call it the patient experience manager. I'm not sure that that's an appropriate term, because people look at that and say, I'm not sure what that's about. But nevertheless, they have a complaints mechanism. But the complaints mechanism is not independent of the hospital. The complaints officer is paid by the hospital. So why would you want to advocate against your own employer on behalf of the patient? So I think there's a problem with that as a starting point. Some of the people that I've spoken with say Why do I want to go and put a complaint to that complaints officer? Because he or she works for the hospital. And now I'm going to get even worse service than I got up to this point because they'll regard me as a person who complains, etc. Whereas with an advocate, it's somewhat separate, somewhat special. So that complaints mechanism is the only complaints mechanism we have. And then if something happens, we can ask for the hospital to declare it a SAC incident, a severity assessment criteria 1 to 4. 1 usually means there's a death that's occurred. 4 means there's some injury that's occurred as a result of some breakdown in the system. But that complaints process, which is the only complaints process we have in WA, is not trying to determine whether this person was disadvantaged by the system. We're not trying to get blame. We're not trying to ascertain who's at fault here. The purpose of the SAC incident is to determine what the health department needs to do to change its systems so that it doesn't happen again in the future. Not to address the matter that's happened, but to make sure that it doesn't happen in the future. So I think that that's not what we're looking for. What we're looking for is for our complaint to be heard and some form of restorative justice to be put in place. Some way that restores my faith in the system. And then my concern around my community's faith in the system, I can point to at least 25 members of my Indian community who have said to me that they're taking their child with illness or their own pregnancies back to India to deal with that because they don't trust the system here any longer. That is a very sad indictment of our health system, that we are willing to go back to a nation that is actually in development stages, not what we consider to be a first world nation. Yes, you will pay for your health system. Yes, you will pay for your health treatment, but you can be guaranteed that you will get the treatment. So, when the now Premier was Health Minister, I said to him, I can give you a written guarantee that if Aishwarya had been taken back to India to have her treatment, she would still be alive today. Because you'd have to pay for it, no question, but someone would have seen her urgently. So, our complaints mechanism is the severity assessment criteria. Then we run into a problem with private hospitals. Joondalup Hospital is privately run. I have a matter there that I'm dealing with where a baby died in utero, and we've asked for it to be declared a SAC 1 incident, a severity assessment criteria 1 incident. And the hospital has come back to us and said, under the terms of our private-public partnership, we, the private hospital, determines if it's a SAC 1 or not. And we don't think this is a SAC 1. Therefore, we're not going to institute an external inquiry. We will just do it as an internal inquiry. And they've come back and said, nothing to see here. That's wrong. But every private hospital works under that public-private partnership. which simply says you don't need to declare it a SAC 1 incident if you don't think it's a SAC 1 incident. Real problem.
So my question is that we proposed of this health advocate and also the health ombudsman. Ashwarya died in 2021. We are in 26, 5 years. After all that Ashwath did, the government apologized. There was recommendations, promises of more beds, more nurses, and everything. Everything that you are saying, the recommendations, everything was there. It's a, it's a all kudos to Ashwath to that he can get that thing from the government. And in 5 years, we are at the same place where we are now again making recommendations of a health advocate. My question is, the cycle keeps going on in a way from a consumer perspective or a citizen's perspective. Something happens, recommendations come out. In 2 or 3 years, we are back at the same situation. How can we break this cycle?
Yes. And that's why I think that we need a patient ombudsman. Now, the purpose of the ombudsman, look, the insurance industry has an ombudsman. The telecommunications industry has an ombudsman. Banking has an ombudsman. So why don't we have a health ombudsman in the medical space? Queensland has an ombudsman. New South Wales has a commission, a complaints commission. In both the cases of an ombudsman and a health complaints commission, they report directly to Parliament. They don't report to the Director General of Health. They're going above that straight to government to say, we need a change in government policy. Okay? Whereas, yes, you're right, all up in Ashwath's case alone, there were 33 recommendations made. How many of those are now in place? I don't know, because no one has reported back to Parliament as to whether or not all of those 33 recommendations have been implemented. Yes, the recommendations come out, but they're literally that. They're recommendations. They're not action items that need to be put in place. An ombudsman can make the recommendations and then set up a review process in place to make sure that there's a report to Parliament from the ombudsman as to whether the health department is fulfilling the actions that were put in place by the ombudsman. So the ombudsman has much more power than a Director General of Health, than a panel of inquiry. A panel of inquiry is simply going to come back and say, and as an example, take Lena and Abdul's case. The recommendation was made by the hospital panel of inquiry that every person who's going to be shifted, every maternity case that's going to be shifted by bypass, if they are close to delivery, that will have to be done by ambulance. And that was going to mean that the health department's protocol was going to be changed. That's great. Soon thereafter, a journalist then asked the current health minister whether she could guarantee that an ambulance will be used in all those cases. And she said, I can't. Why? If that's the protocol that they have to follow, you have to be able to give a guarantee that that protocol will be followed. And I guess in some of the other cases, they've come back and said, yes, we didn't follow the protocol that was in place. we made a mistake, we did something wrong, not in accordance with our protocol. And so now we're coming in with a new set of protocols that will be put in place. My response to that is, if they aren't following the existing protocols, what chance are they going to have to follow the new protocols? Again, there is no policing mechanism that exists. So a SAC1 incident results in a panel of inquiry which comes up with a list of recommendations, and that sits on a shelf somewhere as another SAC1 that has come up with a list of recommendations. There is no one going and putting a time frame in place in those SAC1 reports that says, at such and such a time, we will review to make sure that all of it's done. Now, what's happening at the moment is that oppositions are coming into Parliament and saying, this is what you did. Can you now report back as a government to Parliament as to what's happened? But the reality, Nirmal, is that we have 7 members of opposition compared to 50 odd in government. So we don't have an effective opposition. We need an effective opposition to keep governments accountable. And that's what we're missing in this state. So if we put up a recommendation, put up a parliamentary petition to say that we want an ombudsman, it'll get defeated on party lines. The Greens are interested. They're talking to me. The Liberal Party is talking to me. I'm not sure what the position of the Labour Party is. And they're the dominant party. So there is a problem there. So I think that your question is a very, very valid one. And it's one I've struggled with in the sense that, yes, we come up with all of these recommendations from SAC1 reports. But who's checking to see that those recommendations have been put in place? And that's why I want an ombudsman. There is an Australian Health Practitioners Review Board or Registration Board, AHPRA. AHPRA will investigate, but AHPRA will investigate individuals. A doctor, a nurse, an individual will be investigated to see whether or not they can continue with their registration. Now, let me give you a simple example again. Young Indian lass, 21 years old, goes in to have her wisdom teeth removed. All 4 have to be removed, and it's done under general anesthetic. The day before she goes in for her operation, she has to fill out an anesthetic questionnaire. And it asks you, are you allergic to anything? She says, I'm severely allergic to penicillin. I almost died when I was 4 years old, when I was administered amoxicillin. When she goes into the surgery, the anaesthetist comes up and says, are you allergic to anything? She says, yes, I'm allergic to penicillin. 2 nurses ask her, are you allergic to anything? Yes, I'm allergic to penicillin. 8 times she's asked this question. When she leaves, she's given a bunch of script later that day. She takes the script to the pharmacy, and the pharmacist says, are you allergic to anything? Yes, I'm allergic to penicillin. Pharmacist says, well, you've just been given a script for amoxicillin, so we're not going to give you this. We'll ring the surgery and get a replacement. So a replacement comes 2 days later. They give it to her. It's cefalaxin. She takes 1 cefalaxin and breaks out in a rash. Airwaves are constricted, almost dies, into ICU in Fiona Stanley Hospital, saved her life, comes home about a week later, and she rings the surgery and says, what was all that about? How come you gave me a script for amoxicillin? And why did I react to cephalaxin, which is, I'm not supposed to react to that? And the dental surgeon said, "Oh, no, no, we withdrew that script and we gave you the cephalaxin. You must have reacted to the cephalaxin. We don't know." She then asked for the notes of the surgery. And it turns out that during the surgery, she was injected with penicillin by the anesthetist. We lodged a complaint to APRA. You would have thought, easy case to deal with. APRA has come back and said, nothing to see here. No issue. They accept that she made a mistake and she's put some procedures in place that will deal with what happened. That's unacceptable. She almost killed this girl. And the response is usually, when we've gone to the medical practitioners and the medical professionals, is, well, you're okay now, aren't you? In other words, what are you complaining about? You're okay. I'm okay, but for the grace of God. If it wasn't for the fact that Fiona Stanley Hospital saved my life. So APRA is toothless when it comes to those sorts of issues. And that's my real problem with the system of complaints that exists at the moment. Yes, I can take it to APRA, but the perception people have of APRA is that it is just another government agency. It's not. It's quite independent. So, a commission of the New South Wales structure, an ombudsman of the Queensland structure, either of those to replace the complaints mechanism that we've got, I think will make the system far more transparent, far more accountable, and put some controls in place to make sure that there's a follow-up audit to make sure that things are happening.
I'll come to how the Ombudsman and other agencies in Queensland and other states work. But I have another question before that. I've been to health hospitals and agencies for my family. Touch wood, nothing has happened. We got whatever we needed and we've come out happy and healthy. But when I read about your ombudsman, the mechanisms which are already available. First is the doctors and nurses which are treating you. Then there is that experienced person you talked about.
Yes.
Then there is something called HATSCO.
Yes.
Then there is APRA. Then there is Equal Opportunity Commission, where
Yes.
if you are mistreated or not treated equally,
Yes.
you can go to them. So it's just a maze of agencies who can come in. Then there is Health Consumer Council who can speak on your behalf. Then you can reach out to the minister. Ashwath and other people have, reached out to them. Shouldn't we try to merge these agencies into one so that it's much simpler for, if I have a problem, I talk to my doctor or nurse, or I'll go to this person, and then they will coordinate with whatever is required instead of having multiple agencies
Yes.
overlapping on each other and no one does their work.
Look, I agree, absolutely. I think it will replace a number of those agencies. I'm not sure which ones, but my gut feeling is that groups like HADSCO, HADSCO doesn't have the power that an ombudsman or a commission would have. So it actually is going to replace them altogether, and the ombudsman takes on the task of all of that. So APRA then only addresses, they don't deal with complaints, but they deal with the registration of nurses and doctors that allow them to practice. Okay, so I think an ombudsman who makes a finding against a doctor or nurse APRA would simply register them or deregister them on the basis of an ombudsman's finding. They don't have to deal with complaints. They are only going to, the only complaint mechanism that will be left will essentially be the ombudsman. APRA's complaint process is taken away. They then are responsible purely for the registration and running basically I guess, a database of people who are registered and who can practice. And if an ombudsman makes a finding against somebody, APRA will carry that on their website and show that a complaint had been lodged so that people can go on to APRA to make sure that Dr. So-and-so is registered and has no complaints listed against them. But the minute the ombudsman receives a complaint, they will notify APRA, and that will simply be a record-keeping exercise by APRA. They don't deal with the complaint. All complaints will now go to the ombudsman. I think the purpose of a SAC1 and SAC incident can be confined to the department, because from my knowledge of all of the SAC incidents that I've dealt with, the purpose of the SAC incident is to improve the health protocols and procedures. It's not about an individual's experience. It's about changing the system. It's not trying to find fault as to who was responsible for what happened, but it is about simply going to see whether we need more staff, whether we need a system that says ambulances will be used in these circumstances to transport pregnant women, those sorts of things. So it's not about the experience of Lena and Abdul. It's not about restoring justice to Ashwath and Prasita. It's not about restoring justice to Shandipan's family. It's about changing the health system protocols so that it won't happen again. Yes, that's great, but there's a certain sense of vindication that we would feel if an ombudsman came in and said, it could have been prevented if this, or this had been done, and that doctor or nurse is at fault for not doing this, or this. That then goes to APRA, and APRA either removes their registration or puts conditions on their registration. Yeah, and it may be that, look, the change may be that in future that particular person is not allowed to provide anesthetic services. A case I'm dealing with in Melbourne. Young Punjabi girl. She and her husband have decided that they're not going to have this baby. They're going to have an abortion. It's a very, very simple process. Harjit has gone in at 1 o'clock in the afternoon. Sukhjinder's been told he's not allowed to be there. He has to wait at work. An hour later, the doctor has rung, the surgeon has rung and said, we have some good news and bad news to tell you. The good news is that the operation's over. The bad news is that we're trying to revive your wife. And a few minutes later, she was dead. She should not have died. Period. There is nothing in her history that shows that she was at risk at all. But she died. We then find out later that the person who provided the anesthetic services had already been banned by APRA. And he was still practicing there, providing anesthesia to this girl after having been banned. So who's following up these things? That's what APRA should be doing. If the Ombudsman comes out and finds there is a finding here, APRA should simply be dealing with registration and auditing to make sure that they're not doing anything. Because they put a banning order on this man, but he went to another practice. He's working there. And the outcome is this girl has died. You know? So I guess it is the lack of real policing, transparency, accountability that currently exists with APRA. That's a significant problem. Yeah, so I think that's why APRA should be doing nothing other than what its name suggests. That is a health practitioner regulation authority. That's all they do. Let someone else deal with complaints. And that gives an independence as well.
I think it is the foundation, legislature, judiciary, administration. You separate the powers and each other keeps a check on each other, but you separate them. I don't know why we don't have this thing in APRA where everything is done at the same level and we don't separate so that the health, like you talked about Joondalup campus, where they did something and then they sit in the judgment of
Yes.
what happened.
Yes.
That should never happen. But going forward with that ombudsman thing, there is already a Commonwealth ombudsman.
Yes.
So how effective they are in cases for WA health, and then when the WA ombudsman comes in, what will be their relationship with the Commonwealth ombudsman?
The Commonwealth Ombudsman's powers are very, very limited. Yeah, they don't have the powers to demand people attend inquiries. They can request a person to attend inquiries, but they can't demand it. They don't have the legislative power to demand that someone comes and attends. So the National Health Practitioner Ombudsman, I think is what they're called. Again, limited powers. And I think that a Canberra-based ombudsman is fine to deal with individual practitioners that fall through the cracks of all the other states. I think we should mirror that federal system at the state level, because it's very clear. Health is divided up into funding by the federals, but the provision of all services at the state level. So what we're concerned about is the service that's been provided, and that's very much the domain of the state government. So a national health practitioner ombudsman could not insist on the state health minister attending, for example, and giving evidence as to the way that funding was dispersed here. So I think there is that issue. We've talked about it in terms of, more broadly in terms of what was happening with the inquiry, the Royal Commission into Bondi. The Royal Commission into Bondi doesn't have the same legislative capacity that the federal police have to demand that people attend and give evidence. So APRA, for example, in the case that I was telling you about with the girl who had the wisdom teeth removed, their preferred approach is that we go back to the dental surgeon and the anesthetist and raise the complaint to them. The dental surgeon and the anesthetist have refused to attend any meetings with us because their insurance company has told them not to attend any meetings for fear of legal action being taken. And they're scared what they'll say that we will then use against them. So we're not getting to first base with APRA because APRA said, go and talk to them. And they're saying they don't want to talk to us. So what do we do? So that is a real problem. I don't think that the even if APRA came up with some suggestions as to what needs to be done, I don't think they actively go out and police and audit. So if this particular anaesthetist has done this in this one case, is someone going back and auditing all her other cases? No, because the complaint is about this one. And we don't have the capacity to complain about any of our other cases because we weren't involved in those things. So it is I guess the whole system is very opaque. It is not transparent. It is not obvious. And I would think, Nirmal, that 9 times out of 10, a patient who's been disadvantaged just wants to get better. They don't want to have to deal with the bureaucracy. Who do we complain to? How do we complain about this? Whereas if we simply have an ombudsman who we refer it to, and then they undertake the full complaints process of addressing, calling for evidence, doing all of those things, almost conducting an inquest into that particular person's activities. Yes.
First point of action is mediation.
Yes.
You have someone who has complained. Here's the agency. Try to mediate and solve it without going anywhere else. What it results, in my estimation, is that at the end, when you have mediated and found a solution, that doesn't goes into those reports that something was complained or something bad has happened. In the end result, in the longer period in reports, you don't see problems happening because they've been mediated and sorted out. Do you think we should get out of that thing so that we can make real changes? Otherwise, we'll be keep mediating and keep, hiding things under the carpet.
I think we almost have. So an ombudsman could initiate an inquiry. We know that X number of people die in our health system every year. It'd be a good starting point. If I was the ombudsman, I'd be going into the annual reports of each of the hospitals, and in each of the annual reports, they identify the number of people that have died in the hospital. That's a good starting point for me to go back and say, as an ombudsman, I'm going to review all of those deaths to see if there's a common element in at least some of them. So you can initiate something without having to go get a complaint from somebody. If an ombudsman can do an inquiry into the banking system, inquiry into the insurance system, without having to have an individual complaint. So I think you're right, though. You come to a mediation, it addresses that particular person's issue, but the difficulty with that is that that particular person's issue could have been finalized in one of 2 ways. Sorry, one of 3 ways. Everything's sweet, they're fine, they've gotten over the issues that they dealt with. 2, they have severe disability, but they're alive. 3, they're dead. What are we doing about those people that have died? Who's complaining? We have a problem there. You know, a mistake happens, the person dies. In the cases that I've dealt with, that person who died was usually a child, and therefore the parent can raise the complaint. I'm dealing with one where a young lady died straight after giving birth to twins. Again, Punjabi family, Mon died. So who's going to complain on her behalf? If it wasn't for the fact that her husband heard about me and came and talked to me, and now we've initiated something that can give us some result. But the only way we can get any, I guess, restorative justice in her case is for us to bring legal action. Legal action is expensive. Legal action is also very time consuming. Okay? It's 3 years since Mon died, and we haven't even got to stage 1 of commencing legal action. We've got the reports in from independent experts. We will commence legal action soon. But it's 3 years. 3 years that the father, the twins that were born, and the elder child have no recompense, no restorative justice for the loss of their wife and mother. And we know from our perspective and the independent experts now that she should not have died. She should have been attended to, which comes also to that other point that I was making earlier about the commonality of the cases, a number of them being of our origin. My view's always been that in all of those cases that I've dealt with, the level of, I guess, the pain threshold of some of these young Indian women and Indian families is phenomenal. They don't complain about a pain. And let me say, I often talk about the fact that in my language, in Malayalam, there is only one word for pain. And the word is Vedana. Vedana means pain. In English, we talk about an acute pain, a sharp pain, a stinging pain. We have Vedana. So when someone asks, what type of pain is that? Someone who speaks my language converts that into, it's a pain. But that doesn't describe to a nurse or doctor the type of pain, and that type of pain can lead to a different treatment regime. So, in the Aboriginal community, in the Noongar community, there is no word for epilepsy. So, there is a phrase that says, bad man got involved in a fight, got drunk, and had a fit. That doesn't give the health professional any idea that they're having a seizure that is related to a medical condition called epilepsy, because they don't have a word for it. So it is those things that aren't being communicated that is also a problem. But an ombudsman can go through, find the commonality of all the deaths that have occurred, and say, should we be looking at the systems that resulted in this? Should we we don't expect that every medical professional would be across all of the different cultural issues that are in existence. That'd be impossible. So we do, however, ask that they be aware that there could be cultural differences in the way you communicate. And therefore, it might be appropriate to get someone who understands a bit better what that's about. Get an interpreter. What are the circumstances under which an interpreter is used? That's very important. I have a case in one of the hospitals where rather than get a professional interpreter, they called one of the family members over, and that poor Punjabi speaking man ended up with double the dose of insulin that he should not have been given. So it is that. So every time we talk about the issues that we deal with, my mind also goes to how are people who are nonverbal dealing with this whole issue? How are people who don't speak the language at all? And what are we doing about First Nations and Aboriginal people? They are severely disadvantaged in all of our systems. Yet, for them, look, when we talk about Lena and Abdul's case, for example, that happened in Midland. It has a significant First Nations population. What happens when an Aboriginal person, a mother, is turned away from the hospital to go bypass? They may well go out on the street and have the baby just outside there because traditionally they've given birth at home, etc., etc. So that's a whole different health outcome that could happen, but we don't know. So I think it's about recognizing that services need to be tailored to an individual's circumstances, and there are mechanisms in place that we can call upon interpreters, language services, cultural issues, whatever it may be. An advocate would have that knowledge, and that's why I want an advocate in every hospital. An ombudsman can initiate an inquiry to find out what are the common elements and therefore address those by better advocacy. So there's a lot to be done, but we need an ombudsman with sufficient powers. So we've got to be very careful how we structure that, to make sure that the ombudsman has significant powers to overrule a health bureaucrat, so they can overrule the Director General and demand that things be done if there are health reasons for doing that. Yeah. Yes. Hmm. Look, I think one of the key features is an ability to cut through the bureaucracy. Um, they're both in relatively early stages, so we don't know fully what the impact's going to be. But what happens now is that someone comes to me, say, I immediately take it up with the Director General of Health, who then farms it out to each of the individual hospitals wherever it's occurred. And then I commence a conversation with those hospitals. I emphasize that none of my work is paid work. Okay. So that then determines the level to which I can commit myself to this as well. This is my full-time work that I do. I'm not working anywhere else. I am just doing these cases because there's so many to do. But I don't get paid. So I want the ombudsman there so that I can hand over these 41 cases to them and say, you deal with it. You've got the powers. I don't have the powers. I'm counting on the fact that these are people who I've built a relationship with, who are helping me achieve something for someone who's come to see me. That's a very tenuous relationship. If they change director generals, I'm in big trouble. I happen to have a relationship with this one. I happen to have a very good one with the previous one as well. The one I have at the moment is exceptional. She works very well with me and helps me achieve things for people in the community. So, it's and her position is very clear. She sees me as doing these things, not for myself. None of this is for me. None of this is for my family. But it is for my community, my wider West Australian community. Because if I can achieve change for these people, that will mean that everyone else is also going to benefit because we will make sure that it doesn't happen again. But that comes from my desire to make sure that the community is safe, the community is able to access healthcare. And when I say community, I mean the West Australian community, not just my Indian community. Coincidentally, my Indian community happens to be heavily represented in the dangerous stakes, but that's just coincidental. But there are a number of people from mainstream communities that I help as well. Yeah, so I think that an ombudsman will have legislated jurisdictional powers that I don't have, and that's why we need to. Yeah, and as I say, there will be no longer a need for me to exist. There will be no longer a need for HADSCO to exist. So what we save on the bureaucracy there, we can spend on the ombudsman.